Hello, my friends. I'm Dr. Rachel Storms, and today I want to give you something most people never get in a short doctor's appointment. An honest explanation of why the blood pressure medication that worked beautifully for you at 55 often stops working as well after 65, and what is actually changing in your body that creates this shift. If you have noticed that your readings are creeping upward despite taking the same dose of the same medication you have always taken, you are not alone. You are not imagining it. And the answer is not simply that you need a higher dose. The answer is that your physiology has changed in ways that change how these medications interact with your cardiovascular system. And understanding those changes is the difference between chasing a number with escalating prescriptions and addressing what is actually happening. I want to focus this conversation on the three medications most commonly prescribed for blood pressure in adults over 65: Losartan, Valsartan, and amlodipine. Losartan and Valsartan belong to the same drug class, called angiotensin receptor blockers or ARBs, and what I describe about one applies to the other. Amlodipine works through a completely different mechanism and faces a different set of age-related challenges. By the end of this video, you will understand why each of these medications faces specific obstacles in an older body, what those obstacles look like, and what you can do to either restore the medication's effectiveness or have a more informed conversation with your physician about the next step. Let us start with the central change in cardiovascular physiology that affects all three medications: arterial stiffness. In your 20s and 30s, your arteries are flexible and elastic. They expand when blood surges through them with each heartbeat, and they snap back. This elasticity is what allows your blood pressure to be relatively stable across activity and rest, handling variations without dramatic swings. And it's what makes medications work the way drug trials predicted, because those trials were largely done in younger populations with elastic arteries. By the time you reach 65, this picture has changed substantially. The walls of your arteries have thickened. Calcium has been gradually deposited into the arterial tissue over decades. Elastin fibers have been replaced by rigid collagen. The most accurate way to think about this is the analogy I have used before. Your arteries are no longer rubber tubing. They behave more like copper pipe. They no longer expand and recoil with each heartbeat. They are simply rigid conduits through which blood must flow. This change has profound implications. The systolic pressure, the top number, tends to rise with age, purely as a mechanical consequence of stiffness. The diastolic pressure, the bottom number, often stays the same or even falls slightly. This is a marker of arterial age more than anything else. And medications that work primarily by reducing arterial resistance, like Losartan and Valsartan, become less effective at lowering systolic pressure. When the problem is no longer resistance but rigidity, you cannot soften copper pipe by relaxing the muscles in its walls. The muscles are not the problem. The structure of the wall itself has changed. This is a fundamental shift in what is driving your blood pressure numbers. The second age-related change that affects all of these medications is the decline in kidney function. After 65, the kidney's filtration capacity declines progressively even in the absence of specific kidney disease. This affects BP medications in two ways. First, sodium retention increases, meaning the pressure load the medication must counteract grows. Second, ARBs like Losartan and Valsartan work through the renin-angiotensin-aldosterone system, which is regulated through kidney signaling. Age-related changes in this system can shift the responsiveness to these medications in ways that are highly individual and difficult to predict. Now let me explain why ARBs may seem to lose effectiveness. They block angiotensin II, the hormone that constricts vessels and retains salt. In younger adults, this system is the dominant driver of blood pressure regulation, and blocking it produces a robust and predictable reduction. As we age, other mechanisms like arterial stiffness and sympathetic nervous system activity become proportionally more important drivers. An ARB still works, but its job is now a smaller percentage of the total problem. The medication is doing the same job, but the problem has evolved. There is also a specific issue with Losartan. It is a prodrug. The tablet must be converted by liver enzymes into its active metabolite. This conversion occurs through an enzyme called CYP2C9. Genetic variations affect how efficiently you convert Losartan to its active form. Additionally, common medications like statins can compete for this enzyme activity, potentially reducing the active medication in your system. A switch to Valsartan, which does not require this conversion, sometimes produces dramatically better control without changing the strategy. Now let me turn to amlodipine. The mechanism is different, and the age-related challenges are different. It's a calcium channel blocker. It works by reducing the entry of calcium into the smooth muscle cells of artery walls, causing the walls to relax. But in stiffened arteries, relaxing the muscle is less impactful because the muscle is no longer the dominant determinant of arterial diameter. Second, amlodipine can lead to dependent edema, the ankle swelling, which is one of the most common reasons patients discontinue the drug. This swelling is frequently misunderstood. It is not heart failure, it is not kidney failure, and it's not systemic fluid overload. It's a direct consequence of the medication's effect being more pronounced in the periphery, causing fluid to leak from capillaries into the tissue. The treatment is not a diuretic. Adding furosemide addresses the symptom poorly while creating risks like dehydration and electrolyte issues. The solution is either dose reduction, switching to a different subtype, or adding an ACE inhibitor or ARB to counteract the vasodilation. This swelling has implications beyond cosmetics. In severe cases, chronic inflammation can lead to skin breakdown and infection. And when you lie down at night, that pooled fluid moves back into circulation, contributing to nighttime urination or nocturia. This is a quality of life issue that deserves specific attention rather than acceptance. You don't have to just live with it. Let me also address hidden interactions with supplements. Calcium supplements compete directly with amlodipine at the channels it targets. The advice to separate calcium and amlodipine by at least 2 hours is even more important in older adults whose response is already blunted. Potassium loading through salt substitutes is dangerous with Losartan and Valsartan because they cause potassium retention. Grapefruit juice also deserves a mention. It inhibits the enzyme that metabolizes amlodipine, and this is more pronounced as we age. A single glass can produce a dramatically higher concentration, leading to edema and low blood pressure masquerading as medication side effects. Now here is my recommended strategy. First, monitor your blood pressure at home with a quality cuff. Bring these logs to every appointment. The single greatest predictor of optimal management is the quality of the home monitoring data you bring to your physician. Second, request a comprehensive metabolic panel twice yearly to check kidney function, potassium, and sodium levels. Third, discuss your target BP. For many older adults, a systolic target of 130 to 150 is appropriate, not 120. Chasing 120 in a 75-year-old often requires doses that produce harms exceeding the benefits. Fourth, ask if a combination of an ARB with a low-dose calcium channel blocker might produce better 24-hour control with fewer side effects. Fifth, the lifestyle interventions that lower BP are not minor: sodium reduction, weight management, and regular aerobic activity. These can produce blood pressure reductions comparable to a low-dose medication. It's a meaningful pharmacological equivalent. The typical response of the medical system is to just increase the dose. But sometimes the system doesn't have time to ask the deeper questions. You may need to bring these questions yourself. You now have the framework to do so. Share this video with someone who needs it. It's about smarter medication calibrated to the system you have today. And if you want to understand brain health, watch my next video on memory.